Hello and welcome everyone to our TIF Talk Tuesday. I'm Andrea Millers with Endogastric Solutions, and I'm happy to let you know that we have a special guest, Dr. Ravi Prakash, that is here with us today, as well as Wendy Prophet from Endogastric Solutions. So thank you for joining us. But before we start, I do want to give, well, first off, remind everyone this is a live Facebook event. So at any time, if you have any questions, please feel free to type them into the comment section and we will do our best to answer any questions. So before we start, I do want to give you a little background on our special guest, Dr. Ravi Prakash. Thank you for being here today, Dr. Prakash.
Thank you, Andrea, and Endogastric Solutions, as well as Wendy, for having me over.
Fantastic, thank you. So just a little background for him. He is an interventional gastroenterologist with special interest in reflux disease and endoscopic anti-reflux procedures, complex endoscopic resections, GI oncology, and pancreatobiliary diseases. He is currently employed with Advocate Medical Group and works at multiple locations in the greater Chicago area. After graduating from Bangalore Medical College and Research Institute in India, Dr. Prakash completed his residency training at the Royal College of Physicians in London and at Case Western Reserve University in Cleveland. He then went on to complete a gastroenterology fellowship at Case Western MetroHealth Medical Center, as well as an advanced gastrointestinal therapeutics and interventional endoscopy fellowship at the University of Florida in Gainesville. Dr. Prakash is board certified in gastroenterology and internal medicine and is a member of the American Society of Gastrointestinal Endoscopy, the American Gastroenterology Association, and the American College of Gastroenterology. So again, welcome, Dr. Prakash, and thank you for being here with us this evening.
Thanks again, Andrea. It's nice to be here today.
Thank you. So we're going to go ahead and start our program. We usually always start explaining what is GERD, maybe what is the scientific explanation of GERD, what are the kind of typical or atypical symptoms that people would feel if they were suffering from GERD.
So GERD, as it's in the name, it's gastroesophageal reflux disease. It's a long term, so they've shortened it to call it GERD or GERD. So it's the reflux or the movement of stomach contents into the esophagus, which is the wrong way. Esophagus is a passage tube which starts from the mouth all the way to the stomach, and the contents are supposed to go from the mouth into the stomach. When the contents go in the opposite direction, that is GERD. If you go back to physiology, this is important for us. It's actually called TLESR, or transient relaxation of the sphincter, and it's important for us to burp or release some gas, and this mechanism helps the content of the stomach empty out intermittently after we eat or while digestion. When this happens too often or too frequently, that's when patient starts experiencing symptoms, and that we call it as GERD.
Perfect. Thank you so much. What types of symptoms do patients most commonly experience? You know, is it just heartburn, or, you know, I've heard some patients talking about throat issues. So maybe talk a little bit about some symptoms that they would feel.
So when you look at symptoms, you could classify them into typical symptoms and atypical symptoms. Typical symptoms are the ones we are very much in tune with. They have some pain in the pit of the stomach. They have heartburn or burning in the chest area. They have some regurgitation symptoms where they can actually feel the stuff coming back up all the way up to the throat or the mid-chest. They have sore throat, and sometimes they wake up in the night coughing. So these are some of the typical symptoms that we encounter in patients with GERD. There are a lot of atypical symptoms that I see, considering I've been doing this for quite some time. Patients who have new onset asthma, patients who have chronic cough, either through the day or nocturnal cough, patients who have worsening sinusitis. I've had patients with recurrent middle ear infections, believe it or not, multiple dental erosions. I have treated patients for that. So there are a wide host of symptoms. So we've put them into compartments, calling them esophageal symptoms and extraesophageal symptoms. But the pathophysiology, or what is behind all of this, is the same, where there is movement of acid or movement of the stomach contents in the wrong direction, from the stomach all the way up into the chest through the esophagus. We do worry about some of the dangerous symptoms. Patients who have any difficulty swallowing, patients who have chest pain, patients who have weight loss, they need urgent evaluation. We do tell our patients not to ignore chest pain and not to assume that chest pain is from GERD. Depending on their age spectrum, we always make sure we encourage them and in most instances insist them on getting a cardiac evaluation to make sure we rule out cardiac cause behind all of this.
Perfect. Thank you. And maybe talk about what do you generally recommend these patients initially to do to help manage their symptoms? Meaning, are there food aversions, maybe lifestyle changes or whatnot? What would you normally recommend to these patients initially?
Andrea, we are in an era where we are dealing with highly intelligent patients. They are well informed. They have tried out a lot of maneuvers. They have tried a lot of food avoidances and other measures before they actually show up. In my experience, most patients have had symptoms for at least 5 years with heartburn before they even show up to their primary care doctor. They would have tried some therapies over the counter, such as Pepcid or Tums or multiple other remedies right now which are available over the counter intermittently to start off with, and then more often before they can come to the primary care doctor. At that point, rightfully so, lifestyle measures are the first way to go about. For a long time, GERD was touted as a lifestyle disease. And it was just said, hey, if you have acid reflux, it's a lifestyle issue. Just eat less. Avoid certain foods. Don't drink alcohol. Don't drink coffee. These were the recommendations which were given to the patients. And even though they were following all of these measures, a significant portion of these patient population continue to experience these symptoms. But in answer to your question, lifestyle measures are imperative, very important. They should be explained to the patient. We, in our practice, refer the patient to a dietitian as well, so that they can get some expert recommendations on certain food avoidances. They can get recommendation on some weight loss strategies if they need it. We also partner with an advocate bariatric center, which offer medical therapies as well for weight loss. And this is the foremost measure that we take in treating these patients. And then the next step would be, talk about pharmacological therapies, where you give medications to these patients. And of course, a workup comes, somewhere in between all of this.
Yeah. We'll get into that. I think one of the, not issues, but we talk about kind of unmanaged GERD, or you had mentioned that patients will just go to the lifestyle. It's a lifestyle disease. We have heartburn every now and then. We go to the store and get a Tums or Prilosec or whatever it is, and we kind of self-medicate ourselves. until it gets to the point where none of that is working. So I'm glad you had mentioned that. Can you talk a little bit about unmanaged GERD? One of the big things is next month, pretty soon, in a couple of days, it'll be April, and it is Esophageal Awareness Month, Esophageal Cancer Awareness Month, the month of April. And I'm not, maybe talk about what is the correlation of GERD, and the precursor leading up to potentially esophageal cancer.
So it's very interesting you bring it up. I think we are having this conversation at an important juncture where we have to make people more aware of the situation. If you look at a number of diseases that we deal as in healthcare, for instance, let's take knee pain. And if the pain gets worse, you assume that your arthritis is worse. So the severity of symptoms is linearly correlating to the severity of disease. In acid reflux disease, that's not the case. You can have patients who feel that their chest is on fire and they're going to die with chest pain. And we do an endoscopy and we can find a completely normal looking esophagus. Whereas you may have patients with very minimal symptoms and you go in and you can actually see really bad disease. So the severity of disease does not correlate with the severity of symptoms with regards to acid reflux disease. So we have been educating our patients, our primary care doctors, and our colleagues, our ENT colleagues, our pulmonary colleagues who manage a lot of our GERD patients, that, just because they have minimal symptoms doesn't mean they have minimal disease. So this is something that they should not ignore. We always recommend, get evaluated. For instance, I saw a patient last week who's in the late 30s. He's a pretty healthy looking young woman who was having reflux symptoms intermittently and was self-treating and came to me for an endoscopic evaluation. And when I went in, her esophagus was scarred up and was so narrow that I could not pass an endoscope. And looking at this severe disease, I would assume that she's had this at least for 15 years untreated, but she had very minimal symptoms. So it is important for us to recognize this aspect of GERD and ensure that patients take this into cognizance before embarking on self-treating for a very long time.
Yeah. Oh, gosh, that scared me enough to think about. I appreciate you mentioning that, because I don't think we think about that day to day, as you had mentioned. Everyone, I love how you said it. They think of it as a lifestyle disease, and when it's truly not. So let's go into talking about what are the available treatment options for GERD today. We're starting to kind of go into the medical therapy part of it, and maybe you can break down the different types of medical therapy or different types of medications that you can take, and then kind of what are the next steps after that.
Well, our options are limited when it comes to medical therapies. Unfortunately, we have a class of medications which are called H2 blockers and a class of medication called proton pump inhibitors. These are acid suppressing medications which suppress the production of acid in the stomach. We know that at least most of the damage, not all the damage, but most of the damage in acid reflux disease happens from acid splashing onto the esophagus. So the goal of this treatment is to cut the acid down or take the acid away from the equation, at least to some extent, so that patient experiences minimal symptoms and it reduces the damage on the esophagus. However, this does not fix the fact that the acid is coming up, stuff from the stomach is coming back up. It doesn't fix the anatomy. It doesn't fix the pathophysiology. All it does is it takes acid away from the equation. So this is pretty much what we have as far as medical therapies are concerned. So then we have to resort to patients taking medical therapies once, twice a day and still being unhappy with this. If you look at a number of studies which have been done in patients who've been on proton pump inhibitors over a long period of time, about 30 to 35% of patients are not really happy with their treatment. This group encompasses patients who have a refractory refractory disease, which means despite being on high dose therapy, their symptoms continue to be present, or patients who are having side effects from these medications. So they have to cut down the dose. And when they cut down the dose, their symptoms come back. And now we have a rising subgroup of patients and physicians who are now noticing that these medications, having been used for 5, 10, 15, 20 years, are bearing some side effects on these patients. So the patients or the physicians want to take these medications off them. So you're talking a huge chunk of patients in this reflux disease realm who are not very happy with what treatment they're getting. And we need to offer more to these patients.
Yeah, absolutely. So thank you for that. We do have some questions that I see that are popping up from our Facebook viewers. So I'm going to pass it over to Wendy to get through some of those questions that they have for you, Dr. Prakash. So Wendy, go ahead.
Well, thanks, Andrea. Dr. Prakash, we have some friends who have said they are viewing from Connecticut, Florida, a few other places. So you've got the cold and the warm tropics tuning in. So first we have Lauren, who is saying she is concerned about being on PPIs long term, is concerned and would like to know just options wise. I think we've had some people even tune in recently asking, you know, when do you know that you need to look at another option? I guess is there a certain amount of PPIs that you take, dosage wise or duration wise? What do you recommend?
That's a loaded question. So it's individualized, but I am very aggressive when it comes to younger patients. And young today is probably, I would say, less than 65 years old. I don't want to be discriminative in any fashion, but I'm saying, depending on their health status and quality of life, I am pretty aggressive, because the issue is with taking antacids, you're not fixing the mechanical issue. You're not fixing the issue which leads to reflux. That's the main problem. And these patients need to be assessed with a basic endoscopy. It's a safe and a simple test. And we take biopsies when we go in to make sure there are no complications from chronic reflux disease, and make sure that there are no strictures, there's no hiatal hernia. If once all this is ruled out, we evaluate if they're a good candidate for some form of reconstruction to make sure we can reconstruct the flap valve. Previously, we've always had surgical options, but they have been fairly invasive. There have been some minimally invasive options, but endoscopic therapies, TIF by far has done very well over the last 14 years. It's been around since 2008 when it was FDA approved. And we have long-term data over tens of thousands of patients where patients have achieved remarkable persistent benefit from this treatment. So this is something that patients can be considered for. They need to talk to their gastroenterologist, or go to gerdhelp.com and find a local physician who is adept in this technique, and have a frank discussion. What does it entail? What are the risks? What are the benefits? Are they a candidate for it? And then take it from there.
Very good. Thank you. So Rick had a question, which I haven't seen this before, but I thought it was excellent. Can an upper EGD make a hiatal hernia or an LES even looser, resulting in your acid reflux worsening?
No, that's a good question. Well, they would think that you're shoving a pipe down the tube, down the esophagus, and is it going to loosen the valve? No, the valve, it's a muscular valve, so it can stretch and it can contract. So, and the upper endoscopy, over the last 15 years I've been doing this, has gotten flimsier and flimsier. There is no way that it can cause any damage. It's one of the safest procedures that we do. The risk from the procedure is about 1 in 10,000 or less. So it's a very safe procedure to do. And it takes about 10-15 minutes. We glean a lot of information from it. And basically what we try to do is to risk stratify the patient. We put them in different baskets. And like I said, patients with GERD, the symptoms do not correlate with the disease. And just yesterday, I saw a patient who has probably 70% of her stomach in her chest. And she came for an endoscopy and she had absolutely no symptoms. She was taking over-the-counter Pepcid 2 to 3 times a week, and that was it. And when we did the endoscopy, most of her stomach is in her chest. And I told her that I think we need to fix this because you're prone for other complications, including the stomach turning on itself, we call a torsion, which is a medical emergency. So it is worth getting evaluated depending on the chronicity of symptoms. And the patient needs to have a frank discussion with his or her primary care doctor and the gastroenterologist if they have one.
Thank you. So Connor is curious about what causes a reflux valve to fail. Now, we talked a little bit about that earlier. Are there any specific causes that you can point to? Is it more ambiguous?
Well, there are different factors which are involved in failing of a valve. Age is one factor. And as we do get old, our muscles get weaker. And the sphincter or a valve is a muscle. And our sphincters tend to get weaker. And unfortunately, some sphincters give way a lot sooner than some of the others. The other explanation is in patients who have the hole or the hiatus where the food pipe or the esophagus gets into the stomach. If that gets wider, then even though if you have a functioning valve, but if your stomach slips up into the chest and you have a hiatal hernia, then the valve becomes non-functional as a result of that. Obesity is an important risk. Patients who have large meals tend to stretch out the stomach and stretch out the valve. And then you have patients with some connective tissue disorders and other conditions which can predispose to a weak valve.
Got it. Thank you. One last one, Andrea, and I'll turn it back over to you. Jane is asking, I have GERD and asthma. I'm having pain. I'm on Nexium and need to have an exam. Can you explain what would occur?
Exam in terms of an endoscopic evaluation is what the question is pertaining to?
She's saying specifically of her stomach. However, I have a feeling you'd kind of be walking her through what the diagnostic workup looks like.
Got it. I think, we have some very good technology available to us right now, which can conclusively prove or disprove whether patients have acid reflux. I do this routinely in patients who have extraesophageal symptoms. We get referred patients with very similar presentations, patients who have, like I said, dental erosions, recurrent sinusitis, and laryngopharyngeal reflux, where they present to the ENT doctor with the sore throat or chronic cough. And when they put their nasal scope down to the throat, they see their vocal cords swollen. They're red and swollen. And the most common cause for this is acid reflux. It could also be a postnasal drip, but it's mostly acid reflux. So in order to prove or disprove this, what we do is we do an endoscopy. And during the endoscopy, I do a couple of things. I use a technology called EndoFlip, which can measure the pressures in the lower esophageal sphincter and prove that if it is loose or not. And if it's a loose or a lax sphincter, then it's most likely that patient is having acid reflux. And I also use a different technology called Bravo or pH manometry. All it does is it measures the acid reflux. So we put a tiny little chip on the top of the valve in the esophagus, and that stays there for about 4 to 5 days. And it measures the amount of acid which is coming up the esophagus. And thereby you can very objectively tell the patient that, hey, your asthma is probably related to severe acid reflux, or the other way around. You're assuming that the asthma is from acid reflux, and I have done this a bunch of times as well, where patients are on high dose antacid therapy for years, assuming that it's all acid reflux, but it's not. So we put them in the right basket by investigating them. So I think it's important to do a thorough workup, especially in patients like that. It's safe. The whole testing maneuver takes about 15-20 minutes, and patients go home the same day. And we, like I said, we glean a lot of information from this and help the patient make informed decisions about what they want to do in future.
Wonderful. Thank you for that. All right, Andrea, back to you.
Thank you. I do see more people asking questions. We will get to them after we go through a little bit more of the program. So don't you fear. Keep asking your questions, and we'll try to get through them at the end of this. We talk about the TIF procedure kind of fitting that treatment gap, right? You had mentioned we've got medical therapy, and then maybe we can talk about, surgical therapy, and kind of TIF is in between that, if you will. Can you explain that continuum, if you will, treatment continuum, and then also maybe explain a little bit more of how the TIF procedure works, if you will?
Well, so obviously we've gone through medical therapies where you're taking an antacid once a day in the morning or at night, or sometimes twice a day, depending on your severity of symptoms. And if it is for a brief duration, situational 2 or 4 weeks, you had a stressful life event, or you broke your knee and or your leg, and you had to take anti-inflammatories, and it resulted in some ulcers, and you had to take the antacids. That's a whole different story. But once you cross over that and you're resulting in having symptoms for months, then you have acid reflux. At this point, you really got to decide what you want to do. So you go over lifestyle maneuvers and then try to wean yourself off the antacid. And mind you, going back 15-20 years ago, we would dish them out like candy. We would, a patient would come and see us, and we would give them a prescription for an antacid therapy, and they wouldn't see us for years. And we would just, either us or primary care doctors would be giving refills on it, and they would say, yeah, it's fine. You can take 1 or 2 a day. And in the last 4 or 5 years, we've had a lot of information about how long-term high-dose therapy can be harmful. The effect of high-dose therapy on bones, bone thinning, the effect of high-dose therapy on some kidney diseases. The fraction of patients affected are small, but it's real. The bone disease, the effect on bone disease is higher. It also affects the nutrients absorption from the stomach. I have done TIF on a couple of patients with recurrent hypomagnesemia, which means your magnesium levels are low. And they had to be on high-dose antacid therapy for reflux disease, and that prevented the absorption of this very essential chemical in your food. So, and if they take high doses of magnesium, they would get diarrhea, supplemental magnesium. So they had to actually get TIF, and it recovered miraculously, because they didn't have to be on PPI. So you have these situations. So so that's one end of the spectrum. And then on the other end, you have patients, like I said, 8-10 centimeter big hiatal hernias where the stomach is in the chest. Sometimes part of the colon is in the chest, and the surgeons have to correct the anatomy. So they bring the stomach down, and they can do a flap valve, or what they call as a Nissen fundoplication. The Nissen fundoplication is different from TIF. It's a surgically done, initially it used to be done open, and now it's done robotically or laparoscopic. And they take part of the stomach or the fundus, and they wrap it around the lower esophagus. If it's done well, patients do well, but studies have shown about 30 to 50% of patients end up with what is called gas bloat syndrome. That seems to be the main issue, along with some difficulty swallowing, because it's hard to assess how tight the wrap is sometimes. And if the wrap is too tight, it really cannot be undone. That's the main issue. We've had referrals asking for dilations and stretching of the Nissen because the wrap was a little tight, and now patient cannot swallow because they go from an opposite problem. They go from a problem where their valve was too loose now to a valve that is too tight.
They're trading one for the other.
Trading one for the other, exactly. And without going too much into how everything works and bore the patients, the way you do the Nissen wrap is you do it on a collapsed stomach, whereas TIF, you do it in a completely inflated stomach. So it's if you think about tying a knot, right? If you tie a knot on at the valve area in a collapsed stomach, and then you blow up the stomach, the knot can become too tight because the angles become sharp. What I like about TIF is that you do the reconstruction of the flap valve in a fully inflated stomach, maximally inflated stomach. So you can't have the stomach any bigger. As a result, patients have very minimal dysphagia or have very minimal gas bloat post-procedure. That is something that we've seen consistently over the years, which has really encouraged us and our surgical colleagues to change practice and really deliver what is best for our patients. So long story short, to what you were saying about trying to bridge the therapeutic gap. So you have a significant number of patients who are taking antacids, and about 30 to 35% of them are not happy with it. And on the other hand, you have patients who are going for complex surgical therapies. And if you look at the literature, you have only 1% of patients who are currently being referred for surgical treatments for GERD. So then you have this huge gap in between where patients like you and me who try to do everything right, but for no fault of theirs have a floppy valve. And they don't want to take a medication. They just don't like being dependent on medication. Or they're having side effects from medication, or so on and so forth. We've gone through this. So TIF comes in as a crucial tool. We can offer this to our patients. We can say, hey, this is something that we can do. 80 to 90% of the patients come off the medications, which is a huge plus. You have patients who have no incision. It's just done endoscopy. It takes about 20 to 30 minutes to do the procedure. Patient wake up and then they stay overnight. We've tried to send patients home the same day as well, and it's worked, but I'm a little bit conservative. I want to make sure everything goes well and we discharge patients the right way. So we keep them overnight and send them home the next day. And with regards to safety of the procedure, it's just as safe or actually safer than a colonoscopy. So, I think there is not much to lose in terms of getting evaluated. But I think being an interventional gastroenterologist, I feel good about having this tool in my armamentarium, so that it is something that I can offer my patients, rather than saying, I'm sorry, I know you have a problem, but we can't help it. Either for surgery or you could just stay on pills, and that's that. So I feel good about the fact that it's being so helpful for our patients.
Fantastic. And you had, I don't know if you touched on this a little bit, maybe you can. I know that I believe you partner with a surgeon to do kind of what we're now calling a CTIF, which is a combined procedure for a hiatal hernia repair and the TIF procedure. Can you talk a little bit about how the hiatal hernia repair kind of works with the lower esophageal valve, and how that repair together makes kind of an optimal barrier?
Sure. So if you look at the flap valve, right, the flap valve at the lower esophagus, which is really a protective mechanism that we have to prevent the stomach acid from coming back up. It's done very well. I mean, the way God has made us is remarkable, and we only try to get somewhere close to how it has been done before. So it's damaged for whatever reason, but once you have a hiatal hernia, so you lose the mechanism. Part of the lower esophageal sphincter or part of the valve is by the diaphragm or the breathing muscles, and part of the valve is the actual sphincter at the lower end of the esophagus or the food pipe. So correction of the hiatal hernia is extremely crucial. Even if it is a small hernia, about 2 centimeters, I still would encourage my patients to have the hiatal hernia fixed. We partner with our surgical colleagues who are excellent at fixing hiatal hernias. And it takes just an hour or so to have that done. It's done very safely. And they bring the stomach down into the abdominal cavity, and they tighten up the crura. And this in combination with TIF, this is called the combination TIF or the C-TIF, where you fix 2 parts of the anatomy, where you fix the hiatal hernia and fix the crura. That's the surgical part. And then endoscopically, we go fix the valve. So these 3 are crucial, which has shown remarkable benefits and persistent improvement and persistence of improvement in patients. So that is what we shoot for: exceptional care, exceptional outcomes, and we need that to stay like that. So
fantastic. Thank you. Can you talk a little bit about the pre and more so post procedure protocol that you do? A lot of patients that come on always ask about the diet. They always hear that the TIF diet is so hard, but maybe explain what you normally tell your patients to do post procedure and leading up to procedure as well. Do you keep them on PPIs afterwards for a little bit? Do you take them off completely after the TIF?
So leading up to the procedure, I obviously encourage patients to lose some weight, and then they stay on the PPI till the procedure. And once the procedure is done, I usually have them get some bowel rest for about 4 hours, because we've done some work on the lower esophageal valve, and the body needs some rest before it starts having any fluid intake. In about 4 hours, I start with clear liquids, and we tell the patients to stay on a liquid diet anywhere between 10 to 14 days. The basic reasoning behind this is that when we reconstruct the flap valve, we put about anywhere between 25 to 30 plications of fasteners or sutures down there intermittently all along about 270 degrees of the flap valve. When we do that, it gets swollen and gets edematous. So when you try to eat something, it can get hung up. And your body heals. You just have to give it an opportunity to heal. So we tell patients, just don't push it too much. So usually they stay on thin liquids for a couple of days, and then they start with thick liquids. And for about a week, they do thick liquids. And trust me, I've seen patients. I usually follow patients in a week after the procedure. They are ready for soft diet. and they want to push forward. And I always tell them, be cautious, but just listen to your system, listen to your body.
Yeah.
As far as antacids are concerned, I leave them on PPI for about 2 weeks after the procedure, because we've had work done on the lower esophageal valve. And again, for it to heal, you don't want acid. I mean, you have a fresh wound, and if you keep pouring lemon juice or acid on it, it's not going to heal very well.
Yeah.
Just for a couple of weeks, I keep them on antacids and I have them slowly wean off it. In my experience, at least 75 to 85% of them come off PPI by the end of 3 months.
Wow, that's great. And then what about oh, sorry, go ahead.
No, that's fine. What's the question?
I was going to ask you about activities and work. How quickly can they go back to work and go back to their normal activities?
It depends on what they do. If it's a desk job, or if you're not doing any physically demanding labor, I usually tell patients to take off work for about 2 weeks. But trust me, they are ready to go back to work after a week.
Yeah.
And I always overshoot, and then if they're ready, ahead of time, hey, you know what, you can get back. As far as physically demanding labor, I would say about 6 weeks, especially if they've had any kind of hiatal hernia repair, any mesh placed, because if you look at data, it is between the 4th week to 6th week is when there is maximum rebuilding and attainment of strength in the sutures, what we put. So 6 weeks, I think, is important. I always tell them it's an investment, because what you're shooting for is long-term benefit, and I really don't want to see you in a year or 2 years with the same symptoms. So
yeah,
please stay off work for 6 weeks.
Please be compliant. Be a good patient, right?
Most of them.
Yeah, especially if they're feeling it's hard, right? Because they feel so good, they want to start eating everything right away, which is a good thing. But I do see a couple more questions, so I'm going to pass it over to Wendy to get those questions asked and answered, and then we'll kind of wrap up and conclude the show. So Wendy.
Thank you. So more have come in, Dr. Prakash. We have a question, actually a couple of questions around hiatal hernia. One is, is there a correlation or a precursor when it comes to hiatal hernia being a precursor for GERD or vice versa? And then also, is bending over and feeling some liquid in your mouth a sign of a large hiatal hernia?
Both good questions. I would not say that reflux would cause hiatal hernia. I think it's definitely the other way around. Hiatal hernia would cause reflux disease. It alters the anatomy of the lower esophagus, thereby resulting in a very convenient and easy refluxate of the stomach contents into the esophagus. There is something called the angle of His, which is a very acute angle between the food pipe and the stomach, which we aim to reconstruct with the TIF procedure. And that is actually lost when you have a hiatal hernia. So there is a free flow of contents in the opposite direction. And with this free flow comes regurgitation symptoms, which is very troublesome. When they bend down or when they lie flat, when there's regurgitation of stomach contents into either the esophagus or even the throat. So it's possible, especially if patients are having such severe symptoms of regurgitation where they bend down and liquid comes out of the mouth, it's very likely that they have a large hiatal hernia. Definitely warrants evaluation.
Okay, very good. So I'm going to guess that goes along with Matt's question, which is, should I get a TIF if food comes up after I eat? I'm going to guess that there's definitely an indication for an evaluation.
I agree.
All right. So we also have a question from John asking, and we've talked about difficulty swallowing. If someone has a TIF, do they lose their ability to swallow?
So, we do a very comprehensive evaluation before doing TIF. I think it's at the end of the day, you are doing a structural change to the valve. And we want to make sure that patients benefit from the procedure and have minimal to no adverse effects from the procedure. Your esophagus is a muscular tube, and the valve is at the lower end of the esophagus. In patients who have difficulty swallowing, or in patients who have other concerns based on initial evaluation, if we feel that it's needed, we do what is called a manometry, where we put a small catheter into the esophagus and we check for pressures and we make sure that the esophagus is working fine before we tighten up the lower end of the valve. The incidence of dysphagia is significantly less compared to other forms of anti-reflux therapies. It is there early on for the first few weeks, but it tends to subside. Most of the time, the dysphagia is because the lower dysphagia or difficulty swallowing is because the lower part of the valve, which the reconstruction is done, is edematous and swollen. And once the swelling subsides, the food passage becomes much easier. But I have patients taking pills the next day. They have no problem with that.
Good. So when we talk about surgery in the abdomen, we have Jason asking if he gets a TIF, are future surgeries in his abdomen hard to do?
Great question, but no. I think there is no data, no literature, and I see no indication or contraindication to perform any other procedures just because somebody had a TIF done. So like I said, all we are trying to do is to restore our normal anatomy. We are not changing anatomy like somebody getting a bypass done, a gastric bypass done or something. We're not changing normal anatomy. We're trying to restore normal anatomy. So I see no concern for patients, but that's a valid concern though.
Excellent, thank you. Last one, Andrea, I'll turn it back to you. Well, besides, I did want to say John asked how quickly he could go back to eating cheeseburgers and steak after the TIF. I'm going to guess that's at the end of the recovery period that you discussed, yes?
I would think so. I would have him go easy on it though.
Very good. All right. Lastly, Chad is asking, how do TIF results compare to other anti-reflux surgeries?
As far as efficacy is concerned, it's right up there or even better compared to most reflux procedures as far as efficacy is concerned, how effective it is immediately. As far as the benefit which persists over time, we now have patients, over 10,000 patients followed over 10 years, study which has shown the persistence of benefits and that the benefit tends to stay in for a long period of time. As far as side effect profile is concerned, it does remarkably well compared to other procedures. The incidence of dysphagia, the incidence of gas bloat, significantly better. It's also incision-less and less side effect profile, less complications from the procedure itself, and a quicker recovery time. So I think it's a very safe choice right now for patients who want to be considered. If they feel right, they should have a discussion about it.
Excellent. Thank you. All right, Andrea, back to you.
Well, thank you so much, Wendy. I appreciate that. And Dr. Prakash, we usually like to conclude the TIF Talk, kind of letting you have the opportunity to give the patients kind of your advice. What would be, I clearly heard throughout your whole answers in all of your presentation what that is. Evaluation is key, but what would your advice be to these potential patients that are watching that might be considering the TIF procedure and or have been suffering from GERD for a while now? What would you recommend to them?
GERD is like we talked about, it's a very common disease. It's the most common disease that a gastroenterologist would encounter and will continue to encounter in the office visits. and in the outpatient setting. It continues to be on the rise. We know GERD or reflux disease is the most important risk factor for esophageal cancer. You have other complications before esophageal cancer, such as Barrett's esophagus, which helps us at least detect and prevent complications of GERD. You have medical therapies, but like I said, right now, the available surgical options which are being considered for patients is very less than 1% patients. So we now have a safe and an effective therapy which can bridge the gap. So right now, TIF comes in here as a therapeutic gap to bridge the therapeutic gap between patients who have medical therapy, unhappy or refractory to medical therapy, and who don't feel that they really want to go under the knife for surgical therapy. It is important to have a discussion with your primary care provider or with your gastroenterologist. By far, I always insist on patients getting evaluated. There is no harm in getting to know what you have and in which basket you fall into. You could have a motility disorder. You could have eosinophilic esophagitis or an allergy disorder. You may not have reflux disease, or you may have raging reflux disease with complications. We don't know until we look into it, because like I said, the severity of symptoms in reflux disease does not correlate to severity of the disease itself. So the symptoms and disease don't correlate. So marching on to April, which is Esophageal Cancer Awareness Month, I think it's important for us to talk about evaluation. And I've been doing this for quite some time, and I feel comfortable advocating it to my patients, and we've had terrific outcomes from it.
Fantastic. Thank you so much, Dr. Prakash. And if you are in the greater Chicago area, you can find Dr. Prakash, or if you're not, you can visit gerdhealth.com. That is our website. And we do have a physician locator on there where you can type in your zip code and or view by state where your closest TIF trained physician is near you. So again, Dr. Prakash, we can't thank you enough. I know the patients that are watching, they're all giving thumbs up and saying thank you for this event and your talk today. And from Endogastric Solutions, we really appreciate it. As you know, our mission here is to educate as much as we can, let patients know that there are options outside of just taking long-term PPIs and or surgical options. So again, thank you very much. And for all of the watching, thank you. And you can catch us next Tuesday for our next TIF Talk. So everyone have a great evening, and we'll catch you next time. Thank you.
Thank you. Appreciate it.
Welcome.